Welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
Well, I've just come from an absolutely remarkable keynote today, and I have three of the keynote speakers here with me. I'm so incredibly lucky. We have Phillip Pearl. Hello, Phillip.
Hello.
Hello. Welcome. We'll go into introductions into where everyone's from in a second, but then we also have Christophe Matthys.
Yeah.
Is that was good? Yes. And then we also have Àngels García-Cazorla.
Good.
Have I said that okay?
Yes, perfectly.
Everyone is so kind to me when I'm here. Thank you so much for being here. And your keynote was titled Creative Interventions in Pediatric Neurology. And I know that this is an area that so many people will be interested in because, as we were just talking about, so many of the patients that we see, families that we see, they live with someone or a child that has epilepsy, and it really is life-changing. And so there's a source of great information out there online, but sometimes too much and not particularly targeted. And I think this is going to be a great conversation for it. But before we get into some of the topics you covered, I might get each of you to tell me a little bit about your working area and where you're from. Àngels, I might start with you first.
I am from Barcelona. I'm working in Hospital Sant Joan de Déu.
Lovely.
I'm a pediatric neurologist by training. I'm a specialized in neurometabolic disorders.
Wow, fantastic. Thank you very much. Got a lot of questions for you, and for sure. Christophe.
Hi. So I'm Christophe. I'm working for the UZ Leuven, University Hospital Leuven, and the University of Leuven, where we use food as adjuvant therapy. And we do that with collaboration between the dietitians and the medical doctors, on the one hand, in the clinic, but also in the research.
That's amazing. That's fantastic. Thank you very much. Phillip.
Hello, I'm Phillip Pearl. I'm the Director of Epilepsy at Boston Children's Hospital and the William Lennox Chair and Professor of Neurology at Harvard Medical School. I'm past president of the Child Neurology Society and the Professors of Child Neurology. Those are the major academic organizations of pediatric neurology in North America.
Amazing. Wow. This is a wealth of information. As I was looking and preparing for this as well, I thought, well, I don't know what you guys are going to be talking about. So, but I have seen you've done some things we've put online for me to have a look at as well. But what I found really interesting is how, again, for you to be brought together from your different perspectives, from your different areas of specialty. And I thought we could break it down into a few of the different areas that you spoke about. And first of all, perhaps let's talk about personalized medicine. I find this very interesting because I would say whenever I look at grants, which is a huge part of a researcher's job, there's a lot of grants that are really wanting to support personalized medicine. There's a huge direction for that. Do you want to talk a little bit about where we are at the moment with personalised medicine? You presented a very interesting thing about gene therapy and nanocapsules.
Yeah.
Very interesting.
I think it's a very interesting emergent field, and we are having now different options. We're going to have in the future many others. So it's important to see in which every single disease which is the more appropriate, and also not only the disease but in the patient.
Yes.
So I can tell you about some examples, a couple of
wonderful.
examples that we have experienced in our team. So a very interesting experience has been with the treatment, a very simple treatment with food supplement, L-serine, in a genetic neurodevelopmental encephalopathy, which is in fact what we call green-related encephalopathies.
Yes.
These are several disorders that are caused by genetic mutations in the different subunits of NMDA receptors, glutamatergic receptors. So for those specific mutations leading to a loss of function, so the channel is conducting very slowly and not very properly, so we have a low conductance. We discovered in a first work that L-serine can activate the channel, and because L-serine is the L forms of amino acids are the most abundant forms of amino acids in the body. But then they transform into D forms when they got into the brain by the racemase, and these D forms are the active neurotransmitter forms that bind to the receptor.
Wow.
So by giving L-serine, this is going to be transformed into D-serine. This is going to activate the channel that is conducting very low. And this was the theoretical framework, first of all in the lab. So we came to the clinical study and the clinical trial in patients, and in about 25 Spanish patients, and then 10 other patients from other countries using more or less the same protocol. So they were treated for a year.
Yes.
And we studied them with different developmental tests. And we saw that most of all, those with mild forms, that mean mild intellectual disability associated with some autistic traits, they were the ones having the better results, the best results, with improving in different areas, motor, cognition, also daily living skills. Although all of them improved, those with the mildest involvement had the best results. And regarding epilepsy, patients with abnormal EEG studies with abnormal activity, we found 18 patients with those abnormal EEGs, and 5 patients normalized with L-serine, the EEG, and one of the patients with refractory epilepsy also had a good result with a decrease, an important decrease in the frequency of seizures.
Wow, and that sort of thing it's life-changing, really, isn't it? And with a seemingly straightforward, simple methodology. That's really interesting. And in terms of accessibility to that, is that something that it's very specific for that diagnosis, I understand. Is that quite widespread treatment now? If children have green, are they able to access that now beyond research?
I think that it's one of the first options now for loss of function mutations to try L-serine.
Amazing. I love that. And I guess the next thing that you guys really did talk a lot about was personalized nutrition. And I feel like everyone will understand this when you start talking about it, but I feel like I'll just have mushrooms every day of my life now, and I'll probably have kombucha and all the lovely fermented products. I'm a fan. I know that the moderator was less of a fan. But do you want to tell me a bit about where that came from and what work you've been invested into?
Well, let me start with saying that personalized nutrition and what we can do with kombucha and kimchi and this kind of fermented foods and so on is still far away from each other, because within the context of personalized nutrition, we are very good in kind of typing yourself, screening. I mean, Phillip was referring to all the omics area, so we can really bring you into a specific map. The big question is then, okay, but what should be then the treatment? Because we have a huge variability, but how are we going to treat people? And that's where we, within the context of personalized nutrition, are still a little bit lacking evidence as such.
Sure.
But on the other hand, what we see is that quite interesting studies are recently published, for example, about the butyrate, which is a short-chain fatty acids. Short-chain fatty acids normally produced by the gut microbiota, can pass the gut-brain axis, and then can have positive effects on brain functioning, and shown in patients with Parkinson. And of course, there the question is, which other type of foods can bring these butyrate? Because normally butyrate is a metabolite produced by the consumption, or produced after the consumption of fiber. But for example, if the human body has a lack of energy, then the butyrate will not be used as a component, as a ketone for the brain, but it will be used as an energy source. And so kind of looking what could be then other ways to absorb short-chain fatty acids. And then you start looking at fermented foods. Think about kefir, for example, as well. These kind of products, they contain short-chain fatty acids and would allow you to immediately be absorbed in the small intestine. So even from the moment they have left the stomach, they can be absorbed and can immediately be transported to the brain.
Wow.
If you would ask me now, how much kimchi or kefir do I have to drink before I can avoid a seizure and we can use that in refractory epilepsy, I cannot answer that.
Yeah.
We are not yet there.
Yeah.
I mean, the dose response is definitely not yet there.
Sure.
But we see quite interesting trends that we could see. And I think that is really promising field of
That's
research.
the start, isn't it? If you can start to see the trend and then understanding what's happening from there. But I think what's also really remarkable about that is, you know, often in mainstream media, they'll talk about the benefits of these kinds of foods, and what can be lost with that sometimes is where the science is actually up to and understanding what it will do.
Well, the thing is that there are two things, of course. I mean, when we talk about food, I always say that it's an adjuvant therapy. Why is that? Because you have a whole form of regulation as well about food.
Yes.
Yeah? And the big difference between food and medication, for example, is that medication is well defined and needs to prove an effect. For example, if I'm talking now about kefir, but you can buy here kefir where we are now, just around the corner, but you can potentially buy it close to your home as well. The amount of short-chain fatty acids could be completely different between the one you buy at your home and the one that you buy here.
Yeah.
And then, of course, it becomes very difficult if we start talking about doses, of course, because you speak in doses of kefir. You're not going to talk about doses of these butyrate because people, well, with all respect, the majority of the people do not know what the butyrate is and what the content of the kefir is, which is normal. And that is not on a label or something like that unless we add another level of legislation. And I'm not sure if we have to do that, but so that is a little bit where this hurdle is, or where we have this kind of gray zone sometimes, and a lot of people tend to over-interpret the beneficial effects of food, while I have something like, yes, food can be very supportive, but is not necessarily going to heal a lot of patients, for example. It can be really an added value. And I think that's where sometimes the difference is. And of course, in the media, it's very easy to put your title, kimchi will heal you from whatever. That will sell.
It's really tangible, isn't it? It's something that you can do yourself. You can see the appeal of that, but we've got to be careful about what we actually
But that's also what you see nowadays in these kind of do-it-yourself enteral feeding. I mean, that is also a trend, what you can see.
Yes.
People start making their own enteral feeding.
Yeah.
Is that ideal?
Yeah, there's a lot to
sometimes
talk about
start from a food hygiene / safety point of view and that point of view. But
yeah, that's true. That's true. When you consider how many children do have a PEG and do receive their nutrition that way, there's a lot of questions. Now, Phillip, you've probably had the longest way to travel to be here. So thank you for being here and staying past the time that you did your keynote. What it really intrigued me was when you were talking a lot about the more surgical interventions, and it's very nice to sort of hear you talk a lot about just sort of summarizing into that one space, because there's a lot of new technology that's out at the moment. I know it's too much to cover in just, in a few moments, but if there are some highlights that you'd like to pick out, the newest innovations, what would they be?
Oh, thank you for the question. Well, in terms of medically refractory epilepsy, which means trials of at least 2 good anti-seizure medications have failed the patient.
Yeah.
We now have interventions from diet to surgical. And surgical is not just resecting or removing or taking out the brain. Now it's also a matter of using lasers to ablate or use heat, and neuromodulatory devices where we're modulating the activity of the central nervous system, whether through open or closed loop stimulation, meaning we have devices now that actually record the EEG in real time and zap the brain to stop a seizure. So there's so many new options. But when you're asking really about targeted therapy, personalized therapy, and Christophe mentioned the omics, and this is very important because really this has all been enabled by the mapping of the human genome. And we've gone from genome, we have exome, we have metabolome with foods and many chemicals, and just about everything goes into the metabolome. But what this has done, it's enabled us to map the more rare diseases initially, the monogenic ones, the ones caused by a particular gene, map them to a gene, and then come up with targeted therapies for that individual. They, unfortunately, may only be applicable to one individual or one variant. we used to call a mutation. Mutation is actually the process of the gene having an abnormality. Now, these are called variants, pathogenic variants versus benign variants that we all have versus variants of uncertain significance. But by unlocking the genomics of our diseases one at a time, we have come up with personalized therapies applicable to an individual or perhaps a small group or even a large group of individuals, from enzyme replacement therapy to gene editing to gene replacement therapy. I showed an example in the course of gene replacement therapy for a little girl with congenital Parkinson's disease, the deficiency of that enzyme that produces dopamine and serotonin, aromatic amino acid decarboxylase. And this is an autosomal recessive condition. This is one of many rare diseases, but rare diseases aren't so rare in aggregate, especially in this community of children and adults with neurodevelopmental disabilities. So we're conquering the rare diseases one at a time by giving enzyme replacement therapy, gene editing, such as antisense oligonucleotides, or soon to be direct therapy utilizing mRNA, messenger RNA, and now gene replacement therapy. The big challenge also, I should say, is the majority of folks with more prevalent diseases, probably not monogenic epilepsy, but epilepsy caused by a constellation of different genes interacting in a certain way, or epigenetics, where there are factors that regulate the genes themselves, some of which are environmental, that are at the heart of a lot of our conditions. So the big challenge now, besides everything else we've talked about, is going from personalized therapies for these relatively rare monogenic diseases, meaning there's one gene involved, to devising targeted therapy for more complicated but more prevalent, more common diseases. Just think about this. For the last century, the treatment of neurologic conditions has been symptomatic. We treat the seizures with anti-seizure meds, but we haven't treated the underlying cause until now. And that's what personalized therapy enables us to do.
Gosh, that's exciting when you put it that way. God. What does that mean in terms of, when you think about a family that comes to see you, which all of you would experience, and they have these big questions, what's the pathway for them at the moment? I guess everyone's always wanting to know the timeline. When can this happen? What are the possibilities at the moment? I know it might be different in different parts of the world, but Phillip,
I actually have to inject some reality into this. The same way Christophe said, and his research is fantastic, but we don't quite know exactly where we are with, for example, using these nutritional interventions and how effective they're going to be, or how contributory. They're clearly going to be contributory to the health of the patient, but are they going to overcome the disease? In the same way, where we are now is making diagnoses of conditions that we never had a diagnosis before. For example, take Dravet syndrome, severe myoclonic epilepsy of infancy. Charlotte Dravet described that from France decades ago. And it wasn't until the early 90s that the sodium channel 1A, called SCN1A gene, was realized to be responsible for 90+% of these cases. So where we are now is trying to get an accurate diagnosis. But we are still a long ways from having targeted therapy for these diagnoses. Now, we heard before from our colleague from Barcelona, trying to use really interesting rational interventions, such as amino acids or other ways of altering the excitatory inhibitory balance of the brain with nutritional supplements. We're looking at ways, maybe glutamate antagonists as well. Àngels was talking about L-serine as a glutamate agonist, which may help the inhibitory interneurons, but we may need anti-glutamatergic agents. These are still relatively non-specific, but could be specific for someone with a specific mutation of the glutamate receptor. What we need to come up with are treatments that really target the underlying gene, the underlying problem, and we are just getting there now. And we are living in a time of a cultural whirlwind. As I mentioned at the close of the talk, we're living in a time of genomics combined with artificial intelligence, combined with social media, which leads to a loss of control and a feeling of being overwhelmed. But if we can use it to the right effect, we can make tremendous progress. It's coming, but I don't want to be so unrealistic to say we have all these therapies. And if a family comes to me today, I don't want to be so unrealistic to say I have something that's like pulling a cat out of a hat that's going to turn it around.
No, that's really great to know that. And I think that was a beautiful way to finish it as well. You're talking about AI, and AI is on the mind of many people. And, like you can write into ChatGPT all your questions, but where's the reality of it? But I think how you finish it, you're saying they're tools, but they're subject to human intention. And I love how you said that. you can use that technology, but let's not rely on it. Let's make sure that there's a human nature to it.
And just to complete the idiom, I said subject to human intentions and frailties.
Frailties, what you
So
said, yes.
our vulnerabilities and our faults, and you know, we have to be aware that there are going to be limitations, and we have to control this technology somehow. But the potential of this technology is absolutely awesome.
Absolutely amazing. Well, thank you so much for your time. I know that was a very fast whirlwind discussion of your keynote, which is off the back of a lot of work already that you summarized. But at least that just takes us all onto the same page of our discussion that was had here at the conference. And I'm really appreciative of your time for that. So thank you. And to all of our listeners, I hope that was really helpful for you as well. Stay tuned for more episodes. But for now, goodbye. Bye, everyone.
Thank you.
Thank you.